and welcome to today's presentation. Today we are going to look at acid-base balance and arterial blood gas analysis. Now, acid-base disorders are a group of conditions which are characterized by changes in the concentration of hydrogen ions or bicarbonates, which leads to changes in the arterial blood pH. Now, these conditions can be categorized as either acidosis or alkalosis, and their origin may be respiratory or metabolic depending on the cause of the imbalance. Now, these disorders can be evaluated with the help of an arterial blood gas. And so when we say arterial blood gas, we mean the test which measures the saturation of arterial blood, levels of bicarbonate, as well as partial pressures of both oxygen and carbon dioxide. And so it provides a quick assessment of how these gases are exchanged and helps us also to identify any acid-base disorders. In other words, we can say that arterial blood gas is a test that measures the pH and the level of oxygen and carbon dioxide from an artery. This test is used to check the functions of the patient's lungs and how well they are able to remove carbon dioxide from the blood and also move oxygen into the blood. Now, arterial blood gas interpretation is mandatory for all physicians, anesthesiologists, nurses, respiratory therapists, and other healthcare personnel, and its uses are especially important in critically ill patients. Now, there are a lot of methods which exist in literature to guide the interpretation of arterial blood gases, but I will not cover all those methods. However, I will present a logical and systematic approach to enable you make a much easier interpretation of the arterial blood gas. Now, there are four main components of the arterial blood gas. Now, these components include the pH, the partial pressure of carbon dioxide, bicarbonate, and the partial arterial pressure of oxygen. Now, there are 5 simple questions to ask yourself in order to interpret the arterial blood gas. These questions are: you first ask yourself, is there acidemia or alkalemia? And to find out, you must check the pH. The second question is there or is the disorder respiratory or metabolic? And to find out, you must compare your pH with the partial pressure of carbon dioxide as well as the bicarbonate. Then the third question you must ask yourself is the bicarbonate normal? Also, is the partial pressure of oxygen normal? Then finally, you must identify if there is any compensation. Now, these are the 5 steps we are going to use in analyzing our arterial blood gas. But before we do that, let's first review the various components of the arterial blood gas. And so the first one is the pH. The pH determines the acidity or the alkalinity of the body. That is the concentration of hydrogen ions in the body. Now, pH of 7 is neutral. Example, pure water is said to be neutral because it has a pH of 7. Any pH less than 7 is referred to as acidic, and a pH of more than 7 is basic. Now, in the blood, the pH is adjusted to 7.35 and 7.45. This is the normal pH of the human body. So any pH which is less than 7.35 is termed as acidemia, and any pH more than 7.45 is termed alkalemia. Now on this photo, we find the pH of various substances. For example, as we can see, pure water over here has a neutral pH of 7, but blood is slightly alkaline, as you can see, and so the higher the pH, the more alkaline the substance become, and the lower the pH, the less or the more acidic the substance become. And so you can find stomach juice over here being very acidic. The second component is the partial pressure of carbon dioxide, and it is regulated by the lungs through respiration. Any acid-base imbalance which is caused by carbon dioxide is respiratory in nature. And so whenever there is excess acids, the body tries to hyperventilate to get rid of carbon dioxide to solve the problem. It, however, takes more time for bicarbonate to increase to solve this problem. And when there is low acids in the body, the patient rather hypoventilates to keep carbon dioxide in the body, and we find that bicarbonate still needs more time and more days to decrease in order to help compensate for this situation. The third component is the bicarbonate, and the bicarbonate is regulated by the kidneys. And any acid-base imbalances caused by bicarbonate is metabolic in nature, and it takes long time, about 3 to 4 days, to correct these imbalances. Now, these are the components. Now let's quickly move ahead and see the normal values of the arterial blood gases. And so the pH, we have 7.35 to 7.45. This is the normal pH. Then we have the normal carbon dioxide, that's partial pressure of carbon dioxide, to be 35 to 45. I intentionally made it red over here so that you can see that the carbon dioxide has the same values with the second part of the pH. And so the pH is 7.35 to 7.45, and carbon dioxide is 35 to 45, to make it easy for you to recognize it. Then bicarbonate is between 22 and 26. Then we have a partial pressure of oxygen between 80 and 100 millimeters per mercury. Then the oxygen saturation between 95 and 100%. Now, knowing whether these components are high or low in itself means nothing. However, understanding what it means and its application in the clinical setting is crucial. And so, when we pick the various components, a pH which is low means acidosis, and high pH means alkalosis. Carbon dioxide which is low indicates alkalosis, and the high carbon dioxide indicates acidosis. Also, if we have a low bicarbonate, it means there is acidosis, and a high bicarbonate points to alkalosis. When we have a low partial pressure of oxygen, it means the patient is hypoxemic. And if we have a high partial pressure of oxygen, it means, for example, the patient may be on oxygen therapy. Then if the oxygen saturation is very low, the patient is having hypoxemia. We may not have more than 100 oxygen saturation, so that's why I left it blank. Now, having known this, there are certain things we need to keep in mind which are very important before we look at the real interpretation. The first thing I need you to understand is that if the pH and the carbon dioxide go in opposite direction, what it means is the disorder is respiratory in nature. If the pH and carbon dioxide change in the same direction, what it means is the disorder is metabolic. Now, if bicarbonate is abnormal, the disorder is metabolic in nature. And if the bicarbonate is high, then we say there is alkalosis, and a low bicarbonate tells us there is acidosis. This is the first thing I want you to have at the back of your mind. Now, another important thing I need you to remember is what we call mixed disorders. This happens when we have a normal pH but abnormal carbon dioxide and abnormal bicarbonate. In this instance, we have a high carbon dioxide pointing to acidosis and a low bicarbonate pointing to acidosis as well. But we don't know the cause since the pH is normal, and so we say there is respiratory and metabolic acidosis. Also, if we have a normal pH with a low carbon dioxide and a high bicarbonate, a low carbon dioxide points to alkalosis, and a high bicarbonate also points to alkalosis. But we don't know where the problem is coming from, and so we can conclude that the patient is having a respiratory and metabolic alkalosis. Now, if the change in carbon dioxide and bicarbonate is the same, then we must check the percentage difference. After that, the one with greater percentage difference between the two is the one causing the problem. And so, for example, if a patient has a pH of 7.35 with a bicarbonate of 17 and a carbon dioxide of 65, what we realize is that the pH is normal, but bicarbonate is reduced. And as we've seen, a reduced bicarbonate points to acidosis. And we also have carbon dioxide, which is high. And a high carbon dioxide also points to acidosis. So we must determine the percentage difference to know what or where the problem is coming from. And so in this case, the percentage difference in bicarbonate is you subtract the patient's bicarbonate, which is 17, from the normal value of bicarbonate, which is 26. Then you divide it by the normal bicarbonate value, which is also 26. And the answer we are getting is 0.35. Now, the percentage difference in carbon dioxide is you subtract the patient's carbon dioxide from the normal carbon dioxide. And so we have 45 minus 65 divided by the normal carbon dioxide, which is 45. And so over here also we are getting 0.44. And so obviously you can see that the percentage change in carbon dioxide is higher than that of bicarbonate. And so we can conclude that the problem is respiratory in nature. And so this patient may be having respiratory acidosis. Now, anytime you pick your arterial blood gas report, the first question you must ask yourself is there acidemia or alkalemia? Any pH which falls between 7.35 and 7.45 is normal, and so there is no abnormality. But if the pH is higher than 7.45, there is alkalemia, and if the pH is less than 7.35, there is acidemia. Now, this is usually the primary disorder or the primary process. However, I need you to remember that there may be a normal pH and still we may have acidemia or alkalemia. And so in such an instance, you must check your anion gap as well as the base excess, which we shall see very soon. Now, the second question we need to ask ourselves is this primary disorder as a result of respiratory or metabolic disorder? How do we know this? We can only know this by comparing the pH with the carbon dioxide or sometimes with the bicarbonate. Over here, we are going to compare it with the carbon dioxide. And so, anytime the pH goes in opposite direction with the carbon dioxide, the disorder is respiratory in origin. And anytime the pH and the carbon dioxide go in the same direction, we say the disorder is metabolic in origin. And so over here, the pH is low, we have acidosis. And we have a high carbon dioxide, meaning they are going in opposite direction. And so we have respiratory acidosis. Over here also, the pH is low, acidosis, all right, but the carbon dioxide is also low, meaning they are going in the same direction. And so we are having metabolic disorder. Yet, since there is acidosis, we say there is metabolic acidosis. Likewise, if the pH and the carbon dioxide are going in opposite direction in alkalemia, we are going to have metabolic alkalosis because the pH is high, which is pointing to alkalosis, and the carbon dioxide is also high. What it means is they are going in the same direction, and so the disorder is metabolic. And since there is alkalemia, we say there is metabolic alkalosis. Then finally, if the pH is high and the carbon dioxide is low, as we find over here, it means they are going in opposite direction. And so if they are going in opposite direction, the disorder is respiratory in nature. And since there is alkalemia, we say there is respiratory alkalosis. Now let's look at some examples. If a patient comes with a pH of 7.20 and a carbon dioxide of 50, as well as a bicarbonate of 25, what it means is that the pH is low, and so we are having acidosis, and the carbon dioxide is high, and so we are still having acidosis. But the bicarbonate is also 25, which is normal. And so over here, we say there is respiratory acidosis. Respiratory acidosis because the pH is low and the carbon dioxide is high. And so they are going in opposite directions. And so it is respiratory. And since the pH is low, there is acidosis, hence respiratory acidosis. Again, if we have a pH of 7.23 with a carbon dioxide of 30 and a bicarbonate of 20, over here, what we find is that there is acidosis because the pH is below 7.35 and the carbon dioxide is also low. And if the carbon dioxide is low and the pH is low, remember we said if they go in the same direction, then the problem is metabolic in nature. But we also have a low bicarbonate, which is also pointing to acidosis. And so we say we have metabolic acidosis. Again, if the pH is 7.50 and we have a carbon dioxide of 50 and bicarbonate of 25, what we realize is that the pH is alkalemia because it is more than 7.45, and the carbon dioxide is 50, which is also high. Now the bicarbonate is 25, which is within normal. And so since the pH and the carbon dioxide are going in the same direction, we say there is metabolic disorder. And since we are having alkalemia, we say we have metabolic alkalosis. Finally, if we have a pH of 7.60 and carbon dioxide of 30 with a bicarbonate of 22, what it means is that the pH is high and so we are having alkalosis. But the carbon dioxide is low because we are having a carbon dioxide of 30. And so over here, the pH and the carbon dioxide are going in opposite direction. And as we just saw, if they are going in opposite direction, it is respiratory in nature. And so we are going to have respiratory alkalosis. Now, we must determine if there is compensation or not. And by compensation, I mean the physiological changes that takes place in an attempt to normalize the pH. And so the primary disorder is usually followed by a compensatory process as the body attempts to bring the pH back to normal. And so, an important thing that we need to know is that the rate of compensation depends on whether the problem is respiratory or metabolic in nature. And so, respiratory compensation for metabolic disorder is almost immediately. For instance, if someone infused hydrochloric acid through an IV and gave the patient metabolic acidosis, what this means is that there is going to be an excess of acid or loss of base, and so this causes the bicarbonate carbonic acid ratio and the pH to fall, whilst there is no changes occurring in the partial pressure of carbon dioxide. And this is what we refer to as uncompensated metabolic acidosis. Now, this fall or decrease in arterial pH will stimulate the medullary chemoreceptors, which will lead to an increased respiratory rate. So the patient would rapidly begin hyperventilating, thereby washing out the lungs of excess carbon dioxide, whilst the kidneys retain bicarbonate. And this results in a fall of the carbon dioxide and bicarbonate ratio. And there is a rise in the pH, which generates a respiratory alkalosis that will move the pH back to normal. And this is what we call compensated metabolic acidosis. In patients with metabolic acidosis, there is an excess of base or a loss of acid, which causes the bicarbonate carbonic acid ratio and the pH to rise. But there will be no change occurring in the partial pressure of carbon dioxide. And this is what we call uncompensated metabolic alkalosis. Now, this increased arterial and cerebrospinal fluid pH will cause a reduced stimulation of the medullary chemoreceptors. And this will lead to a reduced respiratory rate, and so the patient would rapidly begin hypoventilating, resulting in retention of carbon dioxide and further increase in carbon dioxide to reduce the pH. This is what we refer to as compensated metabolic alkalosis. On this diagram, we are going to see the various forms of compensation as we have. And so if the patient is having respiratory acidosis, then we are going to have metabolic alkalosis as a compensation. Now the trick over here is you should look at the cause of the problem. If the cause of the problem is respiratory, then the compensation will be metabolic. And if the primary problem is acidosis, then the compensation is going to be alkalosis. And so over here, if we have respiratory acidosis, the compensatory mechanism is going to be metabolic alkalosis. Similarly, if we have metabolic acidosis, the opposite of metabolic is respiratory, and so we are going to have respiratory, and the opposite of acidosis is alkalosis, and so we are going to have a compensation of respiratory alkalosis. Likewise, if we have metabolic alkalosis, the opposite of metabolic is respiratory, and so we are going to have respiratory compensation, and since the opposite of alkalosis is acidosis, we are going to have respiratory acidosis. Then finally, if we have respiratory alkalosis, the compensation is going to be metabolic acidosis. So this is the various forms of compensation that we have. Now, the base excess is the extent of metabolic involvement in the disturbances, and it measures the total bases in the body. And usually we may find this from the hemoglobin concentration as well as the chloride and the albumin. Now the normal base excess is +2 to -2, and so anytime we have a negative base excess, the problem is acidosis, and anytime we have a positive base excess, the problem is alkalosis. Now, the next thing we need to know is the anion gap, and it is the difference between concentrations of unmeasured anions and cations. Now, the formula is this. So we subtract unmeasured anions from cations, and basically the unmeasured anions are the sodium and potassium, and that of the cations are the bicarbonate and chloride. Now, this anion gap helps us to determine the source of the metabolic acidosis, and the normal anion gap is 10 to 16 millimole per liter. Now, the next important thing that we need to know are some of the causes of metabolic acidosis or abnormal anion gap. So we may have what we call the MADPALs, and so we have M for methanol, we have U for uremia, then we also have D for diabetic ketoacidosis. Then we have P for paraldehyde, we have I for iron or isoniazide concentrations in the body. Then we also have lactic acidosis. Then also we have E for ethynyl glycol. Then finally we have S for salicylate. Now let's look at some examples of the base excesses and the anion gap. And so in this example, we have Mr. Tanko, who is 27 years old, a recently diagnosed hypertensive patient as well as diabetes mellitus, and was found unconscious. We have the following arterial blood gas report: a pH of 7.20, we have carbon dioxide of 55, then we have bicarbonate of 18, we have oxygen saturation of 85, base excess of -9, and anion gap of 18. And so in this patient, what we find is that the pH is low, which is acidosis. Then we also have a carbon dioxide, which is high. And so we can see that the pH and the carbon dioxide are going in opposite direction, and so it is respiratory acidosis over here. Now we also have a bicarbonate of 18, which is low, also pointing to acidosis. Then we have an SpO2 of 85, which is low, pointing to hypoxemia. Then the base excess is -9, which is severe acidosis, and we have the anion gap of 18, which is also high, indicating diabetic ketoacidosis. And so the cause of this patient's respiratory acidosis is as a result of diabetic ketoacidosis. Now let's look at more examples to finish this presentation. We have a 17-year-old patient who presents to the A&E with tight feelings in the chest, shortness of breath, with some tingling in the fingers and around his lips. He has no significant past medical history and not on any regular medication. His arterial blood gas shows the following: a partial pressure of oxygen of 100 millimeters per mercury. We have pH of 7.7. We have carbon dioxide of 24 millimeters per mercury and a bicarbonate of 24. So what do we make of this? Over here, we find that the partial pressure of oxygen is 100 millimeters per mercury, which is normal. So we check our pH, and the pH is high, and so we say there is alkalosis. But what is causing the high pH? We check the carbon dioxide, which is low, and so pH and carbon dioxide are going in opposite direction, and so the cause is respiratory in nature. Now, we look at our bicarbonate and it is normal. Then we determine if there is any compensation, but there is no compensation because the bicarbonate is normal. Now, what we end up is we are having respiratory alkalosis with no compensation. The underlying cause of this respiratory alkalosis is a panic attack, with hyperventilation, peripheral and oral tingling being classical presenting features. Now, let's look at another example to finish everything. We have a 16-year-old girl who presents to the hospital with drowsiness and dehydration. She has no previous past medical history and is on no regular medication. The arterial blood gas performed on her shows the following. We have a partial pressure of oxygen of 99 millimeters per mercury. Then we also have a pH of 7.25. Then we have partial pressure of carbon dioxide of 20.5 millimeters per mercury. Then we have bicarbonate of 15 milliequivalent per liter. Now, what do we make of this case? Over here, we find that the patient's partial pressure of oxygen is normal, 99 millimeters per mercury, which is normal, but the pH is low, which is pointing to acidosis. And what is causing the pH? So we must check the carbon dioxide. The carbon dioxide is also low. And as we've learned earlier on, if the pH and the carbon dioxide are going in the same direction, then the cause is metabolic. Now, we check our bicarbonate and it's also low, which is also pointing to acidosis. And so the compensation over here is present. And so what we say is that there is a metabolic acidosis with respiratory compensation, as we learned before. If the problem is acidosis, the end product is going to be alkalosis. And if the cause of the problem is metabolic, then the compensation is going to be respiratory. And so if we are having metabolic acidosis, our compensation should be respiratory alkalosis. So this is all that I have for you in arterial blood gas analysis. Thank you very much for your attention. Bye-bye.